So welcome everyone to the IPOSC Masterclass series, this time in collaboration with the International Orthoptic Association on what if the patient had diplopia. I'm Tamara Wignansky-Jaffe, president of IPOSC. IPOSC represents a family of 110 national and supranational societies, and we encourage you to log in to our new website where you will be able to see not only all the webinars, but also learn about the many IPOSC activities. To this audience is particular of interest. These include IPEP, the International Pediatric Eye Training Project in Africa, where many of the orthoptics are involved, SIBA, Save Infant Blindness in Africa, and research initiatives such as a global RCT on red light therapy, low vision, trauma, and amblyopia. You are not only welcome to join our activities, but also initiate projects which will be of interest to you and your society, as many have already done. There's a great deal we can learn from each other and contribute to one another, and that's what we actually learned from being part of IPOSC. I would like to thank the moderators for compiling such an interesting webinar featuring outstanding speakers. Thank you to all the speakers, to our IPOSC communications team, and to Dan Mammert from the American Academy, who provides us with this excellent platform. So please enjoy the session. Don't hesitate to ask questions. They need to be posted in the Q&A box. They will all be answered during the webinar or just after. To our Russian colleagues, you can listen to the Russian translation, view the options at the bottom of your screen, and log into the Russian one. And without further delay, I will now hand over to the moderators, Sihan, JR, and Rachel. Thank you.
Thanks, Tamara, and good morning, good afternoon, or good evening, so wherever you are joining us. And I am Seyhan Özkan from Aydın, Turkey, and I'm the chair of Training and Education Committee of IPOSC. And I'd like to welcome you all to the IPOSC webinar organized in collaboration with International Orthoptic Association and American Association of Certified Orthoptists. And the title of our webinar is What if the patient had diplopia, which sometimes could be a straightforward problem, but sometimes it can be a very challenging problem, both for recognition and treatment. And as Tamara mentioned, so please feel free to leave your questions on the Q&A box. We are going to have the discussions at the end of each talk, and afterwards, if we have some time, we are going to have more discussion afterwards. And if there will be any questions that we could not answer because of the time conflict, and you will see the responses of the speakers in the IPOSC website. And this session is going to be moderators by myself and by Jan Roleff-Polling as the president of IOA, and by Rachel Jenkins and from Asheville, North Carolina, USA, and president of ACO. And Jan Roleff-Polling is from Rotterdam, the Netherlands. And I'd like to introduce the IPOSC speakers first. Yes, please. And maybe have the other slide. Yes. And so you all know the speakers. We have an amazing expert panel. And so our first IPOSC speaker is Lionel Cowell from Melbourne, Australia. And he's a senior fellow at University of Melbourne, Department of Ophthalmology and Ocular Motility Clinic at Royal Victorian Eye and Ear Hospital. Next, please. And the other IPOSC speaker is Jonathan Holmes from Tucson, Arizona, USA, and he's the professor and chair of ophthalmology and vision science at University of Arizona, Tucson, and Banner University Medicine, Tucson. And he is the past chair of Pediatric Eye Disease Investigator Group. Next, please. And Burton Kushner, and he's I can only describe him as the mentor of mentors, and he's now currently professor emeritus in the Department of Ophthalmology and Visual Sciences at the University of Wisconsin. And his, as far as I'm concerned, the last achievement is the Parks Silver Medalist of 2026. So I would like to give the word to Jan Roelof-Polling. Yes, Jan?
Thank you so much for this. First of all, I would like to introduce Anna O'Connor. Anna is widely respected for her work in binocular vision and amblyopia, including her research on suppression and intractable diplopia. So this is very much a topic in her wheelhouse. Anna, welcome, and over to you. Or do we do the introduction first? No, then Fiona. Fiona is a professor in orthoptics of the University of Liverpool and also leading many research in stroke. And she means a lot for orthoptics. She's a lead in vision and research unit, and she looks at non-surgical approaches for symptomatic diplopia. Next one, please.
Hi.
Kyle
Hi.
Arnoldi. Yeah.
Kyle Arnoldi is obviously well known with many of you. She's the clinical assistant professor of ophthalmology at the State University of New York at Buffalo Ross Eye Institute. She's also the program director of the Ross Eye Institute Orthoptic Fellowship Program, and she's the IOA president-elect, and she will be taking on the role of president later this month. Kyle actually is our first speaker today, and she is going to be talking on the assessment of diplopia. Thanks, Kyle.
Thank you, Rachel. It's a pleasure to be here. I was very happy to be invited to speak at this, here we go, on this webinar. I have no financial interests or other conflicts to disclose. I was asked to speak about the evaluation of diplopia in a step-by-step approach. And it occurred to me that all of us on this webinar see diplopic patients every day, but usually that diplopia is associated with strabismus. So I changed it a little bit and decided to talk specifically about patients with strabismus, but who do not have an obvious cause. They don't have obvious strabismus. These tend to be more challenging cases both to diagnose and manage. So we all know what causes diplopia when we have a patient with strabismus. And I'm not going to talk about that. Instead, I'm going to talk about optical causes, unfocused light projecting multiple low-quality images onto the retina, or the new or existing higher-order aberrations. Retinal causes, in which we have anisoconia or metamorphopsia that creates dissimilar images that are no longer fusible, or retinal pathology that cause similar images to fall on displaced macular elements. And finally, the biggest category, the cerebral lesions that cause us to have an inability to fuse similar images, a lack of corresponding points, or a defect in higher processing. Regardless of the type of diplopia you have, strabismic or non-strabismic, we're going to approach it in a three-step process. Number one is to determine if it really is double vision. Many patients use this term to mean something else, something that we don't think of diplopia that way. Then we're going to look at the clinical exam, properties and characteristics of the visual phenomena that they're experiencing, and finally putting those two together to identify where we need to look for the problem. It may be that that first step, the interview with the patient, is the most important one when we are working with patients who are diplopic but do not have obvious strabismus. We have to remember that the description of sensory phenomena, whether visual or auditory or whatever, is limited by our language. I know it certainly is in English. Even words that are common and familiar can be misinterpreted. I've had patients use the word constant diplopia or it's getting worse to mean something that I don't necessarily understand. So we have to speak the patient's language. We have to really dig deep in the initial encounter with the patient to determine what it is they're really seeing. I will ask them, of course, when did you first realize you were seeing double? And this is the first fork in the road, if you will, because those who have acute onset strabismus with diplopia can usually pinpoint when they first noticed it, even if it was years in the past. This is different than those who have optical, retinal, cerebral causes. They sometimes have difficulty determining when they first saw the double vision. It's very fuzzy, even if it was more recent. I also asked this unusual question: did someone else notice the double vision before you did? That seems a strange question to us, but I've had patients who were put in prisms by their corner store eye doctor without ever having diplopia. And they were told, we're putting prism in for this reason, and they don't really understand why, but they've been wearing prism for years. I've also had patients use the term double vision when they really meant strabismus. So this can be a good question to ask. Next, do you see double everywhere you look? And if you do, does the double change depending on where you look? So strabismic diplopia, not always, but commonly is going to be concomitant. Those who have optical, retinal, and cerebral types very often will report that the double vision is pretty much the same. The distance between the targets is the same, regardless of where they look or what fixation distance they are at. And is everything around you double? If you have strabismic diplopia, the whole scene is double. Like the picture here, the cat and the cupboard both are double. Or is only one object in your field of view double at a time? So here we have a picture of a woman, single face, two hands as she should have, but she's got two sets of eyes. If that is what they're noticing, it immediately turns our attention to the cerebrum. What are the clinical characteristics that we need to determine in addition to our typical examination? Of course, we start with, is it monocular or binocular? If it is monocular, we need to know if it's unilateral or bilateral. Now, bilateral monocular diplopia is not uncommon when it's an optical cause, but it is also found in the cerebral category. So this is a good question to ask. Is it resolved with pinhole, or is there no change with the pinhole, or even worse with the pinhole? Resolved with pinhole, of course, that's optical. No change or worse, that could be retinal or cerebral. We need to ask about the clarity and the position of the double image. And for this, it can be useful to have a small whiteboard in your exam room. Draw a big letter right in the middle of that board and have the patient draw what they see around it, if they can. Is that double image faded and overlapping, or solid and separated? Are there more than two images? And there will be some patients who have a cerebral origin of their diplopia who are unable to localize the second image compared to the letter that you've drawn on the whiteboard. That is real. They are not faking diplopia. There are some types of cerebral diplopias that make it difficult for the patient to determine where the second image is, even though they see it all the time. Next, we're going to ask or determine if it's worse, more noticeable in bright versus dim light. When it comes to strabismic diplopia, whether it is a childhood onset problem or something more acute, the diplopia tends to be worse in a dark environment with all fusion cues eliminated when they're looking at a bright target. It's also worse in dim light when you have strabismic diplopia, but also some cerebral types because it lowers the contrast. However, diplopia associated with maculopathy tends to be more noticeable in bright light. This is an important one that you will find in all three of these categories. The symptoms that the patient has don't correspond with their eye alignment. Now, they may have strabismus in addition to the diplopia, but in these cases, the strabismus is not what's causing the diplopia. In fact, both the strabismus and diplopia may have a common origin. And then this is the active testing part where I'm going to determine the response to prism. So these are not patients with obvious strabismus. I'm going to use, usually for me, I use the prism bar and increase the prism and see what happens to that second image. In strabismic cases, it will tend to resolve, but in non-strabismic cases, you may have no response at all, or the images get closer but don't quite fuse, or the response is temporary. We are also going to look for associations. Ocular associations include decreased vision, visual distortion or aberrations, history of anterior segment surgery, history of corneal disease, or extensive visual field defects. Central nervous system associations include head trauma, seizure, stroke, tumor, and some neurodegenerative diseases, particularly Parkinson's and Alzheimer's. All right, so putting this together, these are the things you're going to look for on your exam that will turn your attention away from strabismic etiology to something elsewhere. They can't pinpoint the onset. Maybe through your questioning and testing, you've discovered it's not true diplopia. It's not gaze dependent. The symptoms don't match with the eye alignment. They have associated visual complaints or a poor response to prism. If any of these are present or multiple are present, we need to look beyond just strabismus. So that takes us to optical media. Uncorrected refractive error, dry eye, a decentered IOL. These patients will have monocular diplopia that improves with pinhole, even if it doesn't improve with glasses or contact lenses. They have associated visual problems, and it's not gaze dependent. I'm not going to talk too much about retinal causes because we're going to have a talk about that a little bit later. These are the ones caused by the epiretinal membranes, macular holes, macular degeneration. They have true binocular diplopia. It tends to be more noticeable in bright light. In the case of epiretinal membranes, it is almost always vertical or diagonal. It is not gaze dependent, and the symptoms do not match the clinical signs. And then we have the group that probably contains the most varied diagnoses, but it's the least common. Cortical loss of fusion, anomalous retinal correspondence, or a cortical lesion. These patients can have monocular or binocular diplopia, but it does not improve with pinhole. The diplopia may be paradoxical, it may be intermittent, and it may be limited to certain objects in the environment, but not the whole scene. Because this group is the most challenging, we have to be mindful of this. They are the least common group, but when the cause is cerebral or supranuclear, we have poor fusion potential. The management is typically staged and may have a team approach, and the prognosis is uncertain or poor. Now, this is going to include patients with ARC, early childhood onset strabismus, and now with paradoxical diplopia following realignment. It will also include central loss of fusion, which may be that early childhood onset strabismus patient who was ill-advised and underwent dicoptic exercises that broke through their suppression scotoma, and now they are diplopic. Or it could be acquired following brain injury or disease. These patients are unable to fuse with prism, usually. They are unable to superimpose those two images, and some of them will also have difficulty localizing the second image, even though they see it constantly. Then we have those with extensive visual field loss. They end up with insufficient matching points in the periphery. They will show a relative afferent pupillary defect, an incongruous and rather extensive visual field defect. They may have disc pallor, and they will always have a risk factor for the visual field defect, like a history of stroke or glaucoma. And then this is the rarest group, those who have a cerebral problem. So these are patients who have a history of seizure, stroke, tumor, or neurodegenerative diseases. They don't have true diplopia the way we think of it. They have perseveration, palinopsia, hallucinations, and these tend to be more common in low light. So to conclude, recognizing the distinction between strabismic and non-strabismic diplopia is critical because it's going to change your evaluation, any imaging decisions you might be making, your management, and especially the prognosis. In optical causes, these are very common, easily diagnosed, and management is straightforward, even if it's difficult. The retina cases, this is less common, but not rare. Ancillary clinical testing like an OCT is helpful. Here's the thing with this group. It is difficult to manage their symptoms to the patient's satisfaction. And then we have the cerebral group. This is the most uncommon, typically requires a team approach, and the management may be complex with poor outcomes. Thank you.
Thank you, Kyle. That was so good. Thank you for highlighting the importance of a really good history and the questions that we need to ask to find out what's going on with the double vision. That's so, so important. And just showing us all the different types of diplopia that you can get with non-strabismus. If anybody has any questions, please pop those in the Q&A.
Rachel, may I have a question for Kyle?
Absolutely.
And Kyle, thank you. This was a very systematic talk. I'd like to ask you a practical question. So we know in any paralytic strabismus patient, there is a possibility of presence of accompanying central fusion disruption. And in torsional diplopia ones, this could be a challenge. So in your clinical practice, do you use synoptophore to identify this group, or do you use the white disc test that was described by McCune's group to identify this group? I want to learn your opinion on that, whether you have some practical pearls.
I actually use both. I will start with the white dot to see if I can get fusion there. And then often I will switch to the eye chart to see whatever prism I use that gave them fusion with the white disc test. Will that also work for them on an eye chart? But the synoptophore to me is invaluable for these patients because it does both things. It determines if correcting the torsional misalignment will achieve fusion, and it will also identify those who have central loss, because those individuals will have a very difficult time. They might even get those images very close, overlapping, but they don't tend to actually fuse into one, and they don't stay there. It's constantly moving. So when I have that situation in the clinic, I like to use all of the tests, especially when I think a torsional misalignment is part of the problem.
Thank you. We do have a question in the Q&A, interesting one. Do patients with monocular bilateral diplopia have see more than 2 images?
Some do, yes. And that can happen with optical as well as cerebral causes. In the case of the optical, most patients will say they see 2, but several times they'll say, well, I see 3. The key is that those second and third images are indistinct. When you have a cerebral cause, when you have a patient who's got perseveration, for example, they will see multiple images with each eye. It is a monocular diplopia, but it is bilateral. The difference is that their images are solid. It looks to them like the diplopia that we see with strabismic causes. Multiple copies of the object.
Okay, thank you. And another one, you referred to a team approach in the management of cerebral diplopia. What other professions would you invite to join your care team in these cases?
Well, you may have to go to neurology because if you suspect that there is a cerebral lesion, it is possible, and I have had this experience where a patient was referred for, diplopia, and it turned out that it was really more like a palinopsia, and the patient was having seizures, and it was undiagnosed. So neurology is the big one, but neuro-ophthalmology, if it's a central loss of fusion, we might be working with our glaucoma surgeons, but definitely the orthoptist and the pediatric ophthalmologist or strabismologist will be part of that team.
Okay, thank you. In the interest in time, shall we move on? Sehan?
Yeah, yes, I think, we can also give some replies as written, and then we can give replies afterwards. So I'd like to invite our next speaker, and Lionel Cowell from Melbourne, Australia, and he's going to talk about diplopia after cataract and refractive surgery. And I hope in the audience there are some people who performs cataract and refractive surgery. So yes, Lionel.
Mute. Can you hear me now? And I can't.
Yes.
My camera is on too. Good morning, everyone. For me, it's just after midnight. And I'm going to talk about diplopia after cataract and refractive surgery. Firstly, after cataract surgery. The questions for the 21st century patient with post-cataract diplopia are all those that Kyle mentioned, the standard ones, but as well, we have to ask about anisoconia, metamorphopsia, torsion, and the other questions on that list. We need to learn how to measure anisoconia and metamorphopsia. The 21st century cataract patient will often have motor and sensory cofactors producing their diplopia. The motor cofactors may be pre-existing asymptomatic small phorias or acquired small misalignments from sagging eye syndrome. And the common sensory cofactor is anisoconia, which can be optical or retinal. A typical 21st century patient with post-cataract diplopia is this 81-year-old gentleman who had no diplopia-relevant comorbidities and develops diplopia within a few weeks of his second cataract surgery. He's got very good uncorrected vision and a right epiretinal membrane. And only on specific questioning can you determine that he has right macropsia. Patients never volunteer this. On examination, his versions are nearly normal. His strabismus measurements are all small. He has macropsia of 20%. He fuses a 4-dot for near, but has diplopia for distance. The macropsia secondary to the macular changes means that he can no longer fuse the small phorias that he used to be able to fuse, and he now needs a small prism to make it easy for him to fuse. And when you examine this patient, you really need an OCD refraction because sometimes even very small prisms can make a difference to the ability to fuse. Another 21st century cause is optical anisoconia. There are three important questions. How much anisometropia is it safe to correct with implants? This sounds counterintuitive, but spectacles will often compensate for anisoconia that is secondary to axial anisometropia better than IOLs, better than corneal refractive surgery. And Phil Knapp taught us this many decades ago. First patient that taught me this was a 56-year-old doctor who had right phaco elsewhere for his -8 eye and ended up with a beautiful visual result, 6/8 uncorrected, but constant diplopia. And presumably this was an asymptomatic phoria before his cataract surgery. You can see from his IOLs that his anisometropia was axial, and with glasses he never had any symptoms, but now he has 13% right macropsia. This anisoconia has impaired his motor fusion, and because he has a presumed pre-existing motor phoria, he now has constant diplopia. This diplopia is likely to have been anticipated with a preoperative contact lens test drive. Second question, how much anisometropia is it safe to introduce with IOLs in order to give the most desirable monovision that many of our patients want? In general, less is more. In general, the choice of monovision or multifocals is a difficult choice with good and bad outcomes in both groups of patients. Zane Pollard, some 15 years ago, collected a small number of patients who had surgical vision that seemed to have caused delayed diplopia, diplopia with esotropia that wasn't apparent until 2 or more years after the IOL surgery. And when I talked to him about 10 years after that, he had collected many more such patients, but half such patients present 2 or more years after their cataract surgery, and about half of them are fixed by reversing the monovision, usually with glasses. Another question with anisoconia, can we treat retinal anisoconia by modifying IOL powers? This competition table tennis player, who is also an engineer, noticed diplopia after prolonged near work, developed a retinal detachment, and had retinal surgery, developed a cataract, and developed micropsia. He's got macular changes causing his anisoconia, and because of the combination of his blurred vision, anisometropia, and retinal anisoconia, a usually trivial exo of 1 to 4 prism diopters is now symptomatic. And he's a very careful observer and draws these fern leaves that he examines from 10 meters away and that shows blur and micropsia. I send all these findings to a medical physicist in the Netherlands from whom I buy the anisoconia lenses, and he sends a very complex and interesting recipe for fixing this patient's anisoconia that is totally ignored by the cataract surgeon, who does standard cataract surgery, leaves him ametropic, and the patient has a great outcome. 4 years later, the patient has perfect uncorrected distance vision, no anisoconia, some metamorphopsia, and has resumed competitive table tennis. A new topic, abnormal binocular vision with premium IOLs. And I'm grateful to a refractive colleague who tells me that there are plenty of people with excellent uncorrected visual acuity in each eye post-surgery with these premium IOLs, but who are uncomfortable with both eyes and are told that nothing is wrong. And this is an important pool of patients for us to examine. They haven't been examined well. With cataract surgery and anisoconia metamorphopsia, 3 lessons. Firstly, cataract surgery can cause permanent diplopia in some of these patients. Secondly, metamorphopsia and anisoconia can be beyond the ability of optical devices to resolve in some patients, and the metamorphopsia and anisoconia that is intolerable in some patients causes no problems in others. I'm going to spend a few minutes talking about diplopia after refractive surgery. A very reassuring study was from the US military, over 100,000 cases of myopic refractive surgery in their soldiers, in their servicemen, and new strabismus and diplopia after myopic refractive surgery was seen in 6 patients out of 100,000. Now, this is not a normal population. Military recruits have all been screened, and many patients with visual problems have been rejected. And many patients who might develop visual problems might not be, might find it a career-threatening situation to publicize it. But the best figure we have here is 6 out of 100,000. This is a list of features of the no-worry myopes. The only feature of interest that you may not think of is that if the manifest refraction is greater than the cyclo, think of an underlying exodeviation. Monovision with refractive surgery. 25 years ago, Sherry Fawcett collected these patients. Of 118 patients who had refractive surgery, 48 had planned monovision. Of those, roughly a quarter had abnormal binocular vision. This included visual confusion that she defined as binocular blur requiring occlusion to focus comfortably, or more obviously, intermittent or persistent diplopia. Surgical monovision can cause fixation switch diplopia. The amblyopic eye with the scotoma becomes the fixing eye in some situations, and the habitually fixing eye is now the deviating eye in those situations. It doesn't have a scotoma, and the patient is at risk of diplopia. I think all patients in whom you plan monovision with refractive surgery should have a contact lens test drive. The low-worry monovision patients are those who succeed with an orthoptic exam after a successful contact lens test drive. And my colleague tells me that if they aren't instantly comfortable with the monovision contact lens simulation, there is usually a problem. Hyperopia. All hyperopes are predisposed to esotropia. If recognized and discussed before refractive surgery, it's a patient's problem. If not recognized before refractive surgery, it's your problem. The risk that hyperopia surgery will produce strabismus. Measure the ESO tendency with the minimum plus to reach 20/20 in place. That's the absolute hyperopic correction in place. Then measure the base infusional reserve. It tells you how big the safety net is that protects this patient from symptomatic esotropia. The no-worry hyperope with the absolute hyperopic correction in place, there's no tropia, minimal phoria, measurable base infusional reserve, and little latent hyperopia, and many low hyperopes qualify. Anisometropia, making them better or making them worse. We've talked about this with cataract surgery, that if we convert axial anisometropia, which is safe according to NAP, if we convert it into corneal anisometropia, this is now at risk according to NAP. And if we're treating anisometropia with refractive surgery, we must do a contact lens test drive and ensure adequate binocularity with the contact lens anisocorrection in place. Take-home message for refractive surgeons. Always look at alignment and binocular function with and without correction, but particularly with a planned refractive correction in place. Contact lens trials are gold, And it's worth ordering complex contacts, high cylinders, etc., and take time to trial before deciding upon laser, especially for planned monovision. Thank you very much.
Thank you, Lionel, for this extensive talk. And so because of the time conflict, I can only ask you the Q&A box questions. And the first question that you have that is addressed to you is, how do you measure micropsia for anisoconia? As practical, in practice, do you use the Avaya test or the coincidences? Also, how do you
I
do that?
the Awaya red-green book is good, and I like using proper lenses, this SIZE size lenses, thick lenses that I buy from a Dr. De Wit in the Netherlands, and they're excellent. And I can see that Jan Polling is nodding.
Yes, I have them in my office as well. Yeah.
I beg your pardon?
I have them in my office as well.
Yeah. And I don't have and have never seen an iconometer. But if you give the patient a 660, a 2200E, and you put up a sufficient vertical prism to so the patient clearly sees diplopia, you can ask which one is bigger. If you've got base down in front of the right eye, is the top one or the bottom one bigger? And the patient will tell you. Now there's a trap there that a prism can also cause a little anisoconia. So you need to repeat it base down in front of the other eye to be sure that you get a consistent conclusion from the patient. But I'm lucky. I've got the size lenses. I measure it in every patient. I measure it in every patient who has acquired diplopia.
Thank you, Lionel. And so another question, how do you do contact lens drive test? Well, you mentioned it in that, but I also would like to learn your opinion about the ones who had long-standing aphakia. Do you do the contact lens drive test for them as well?
I have an orthoptist in my office who's can handle contact lenses quite well, and if it's inconvenient, I refer the patient to an optometrist in the community who's good at contact lenses, and they do the contact lens test drive. And the patient aphakia, I don't see those patients.
Yeah, well, post-traumatic aphakia is not very common, but sometimes we see such kind of patients, and I think it is useful. I had a few patients who had in this problem.
I think with those, for me, very unusual patients, if I can demonstrate some sensory fusion in the office with a high plus spectacle lens or a contact lens in the office, then I'm encouraged that they should have, say, a secondary IOL. And if they demonstrate fusion in the office prior to that, then if they get diplopia, I'm likely to be able to fix it.
Okay, thank you. So, Lionel, I think we need to stop the discussion and go on for the next speaker.
Thank you,
Yes,
Sean. Indeed, it is Dr. Anna O'Connor from Liverpool who is the next speaker. So, Anna, please, the floor is yours.
Thank you very much. And thank you for the title I've been given. It's quite a broad one, looking at all sorts of vision therapy. So I'm really going to be focusing on amblyopia in terms of quality and quantity of evidence that we've got to evaluate this question. But I just want to first think about how common is diplopia following amblyopia treatment? And can we actually identify any particular cohorts of participants who are at risk, and then look at the evidence of the binocular treatments that have been coming in recent years? We've got a large amount of binocular treatments, and there's a large push for having novel treatments moving away from occlusion. But how good are they specifically in relation to the risk of diplopia? First off, just looking back a little bit, we did a retrospective study looking at how, because there was lots of anecdotal evidence. Oh, I remember a case of intractable diplopia, and these cases kind of stick with you because you've worked so hard, you know these patients and treating their amblyopia, and then turned up with intractable diplopia. It kind of sticks with you. So rather than just anecdotal evidence, we wanted to send a questionnaire out to all UK head orthoptists, and we got just over half responses, and we got a case numbers of 12 cases of intractable diplopia reported in a 5-year period, and this was 11 following occlusion and 1 following atropine. So if we assume there's no difference between those who responded to the questionnaire and those who didn't, we're looking at a rate of intractable diplopia from occlusion of about 4 a year. Also, it's important to think about the timing of this. I think if we'd done this 30 years ago, potentially it would have been very different. This is after the PDIC, the MOTAS studies all show that actually we don't need to be doing full-time total occlusion. So we wanted to then move on and look at that in terms of prospective data. And what so this was organised through the British Ophthalmological Surveillance Unit. So all ophthalmologists are required to report on cases that are seen in a 1-year period. Now, so this was any new cases of intractable diplopia. And we can see in terms of the frequency, the most common cause was relating to strabismus surgery. So that's not a big surprise. And then the second most common was due to ocular surgery, as we just heard from Lionel, particularly cataract surgery. But what's particularly important here of interest, there were no new cases reported in this 1-year period following amblyopia treatment, whether it's occlusion or atropine. So potentially, has the rates of intractable diplopia reduced over time anyway? Are we getting better at identifying risk and stopping before we should be concerned about causing intractable diplopia? Well, what are those risk factors? Well, obviously, the presence of manifest strabismus, the age of the patient, although we don't actually think about sort of having a magic age of age 7 or 8, at which point their risk increases. Its age is just used as a proxy for where they are in terms of their stage of development, in terms of their neural plasticity. But we also think about the density and area of suppression and their binocular vision potential. So I just want to think about those 2 factors, because how do we measure them? Again, this is an important, so I'm giving lots of questions today rather than specific answers, but in terms of, in the UK particularly, we use the Spicer bar to measure density suppression. And so we said in this questionnaire, the same questionnaire, and said, at what point would you stop your amblyopia treatment because you felt that there was the risk of diplopia was too high? And we can see from this bar chart here, we've got a huge range, right from those who are very cautious, any diplopia, even at the high filters, right through to quite a relatively low filter, filter 4. There seems to be some sort of consensus, maybe around filter 7. This isn't a scientifically based decision. This is just what they've done in clinical practice. My other point in relation to BV and whether they have BV potential, we measure the stereo tests that we use. A lot of the time we can get a negative response, but does a negative response means an absence of binocular vision, or is it that it's not an absence of measurable binocular vision? We know all of our stereo tests have limits, upper and lower. So for instance, the Frisbee that's often used in the UK has an upper limit of 600 seconds of arc. The other factor is the random dot test need relatively good levels of visual acuity to allow you to detect the disparity. So those 2 factors alone means that potentially we're not actually identifying or measuring stereopsis accurately. one example, we did a study using a big 3D TV, and this was the stimuli, this Pac-Man that we used, and the range of disparities were up to about 4,000 seconds of arc. And we did show that some who had a negative response on standard clinical test were measurable on our test. Okay, so thinking about binocular treatments now, lots of different options out there, whether it's using an iPad, whether it's a computer game, having the scotomas when you're watching the movies, whether the modality of creating the differences between the two eyes, whether it's reducing the contrast to the fellow eye or changing parts of the visual scene seen by each eye. But overall, the aim is to remove suppression and improve visual acuity and stereopsis. And it's the stereopsis that we can't do with occlusion. So there is, and potentially it's more engaging treatments as well. There's been a lot of work in this area, and there was quite handily a systematic review in 2024, and there was 20 randomized control trials there, of which there was 1,769 patients. So we've got a big body of evidence developing here. And what I did, I went through all of those 20 papers and just did a search for the word diplopia. Now, out of these 11 papers here, the word diplopia wasn't mentioned. Now, I do appreciate some of these papers were linked to other papers, so that might have been reported elsewhere, but we can see there's quite a range of different treatments here. But of the papers that did mention diplopia, we can see that if we look at this column diplopia, we've got binocular, if it says binocular, that's the binocular treatment versus the standard occlusion treatment. And we've got some cases of diplopia in both the binocular group and in the occlusion group. In terms of how that information was gathered, it was typically either by patient reports, diaries, or reporting at the next visit. But in all cases, the cases of diplopia were intermittent, transient, so that there was no long-term implications. In terms of the recruitment for all of these studies, the age range is from 4 to 38 years, so it does represent quite a broad range. And if we look at the types of amblyopia, most of them have strabismic and anisometropic and mixed amblyopia, although the majority, in terms of the strabismus, focus on the small angle. So these ones are less than 10 diopters, some are less than 4, although we look at the bottom one here, and that was up to 30 diopters. So this isn't absolutely every type of case of amblyopia which we can make conclusions on. We have to make sure our conclusions are based on what has been assessed. Since the systematic review, there's been another randomized control trial. There's still more evidence coming out. This was the UK-based one, and they had one case of diplopia, and again, it was transient, and they also had small angle strabismus. But they did have quite a bit of difficulties with recruitment. Some of that was COVID-related, but some of the other studies have also had dropout rates. Now, is there an element of self-selection? Are some patients perceiving difficulties and they don't continue with the treatment because of that? Maybe that might be a factor. So overall, from what we can see from the evidence that we've got, the risk of intractable diplopia is minimal, and that is based on a large number of randomized control trials, a wide range of ages, but it's also based on no consistent measures of suppression, mostly small angle strabismus, and so in some cases limits with engagement. So going back to my title about nightmares, I'll leave it to you whether this is going to give you nightmares or you'll have sweet dreams. And thank you very much. And as I'm currently in Wales, diolch.
Thank you, Anna. That was a brilliant talk. Yes, well, the reason why I keep asking is that we're being warned, and obviously we have all these nightmares from patients that we see that have diplopia. So are you saying we are just too afraid? Does it not happen? Or are we missing some bits?
I think there is a bit of both. I think we are cautious in what we're doing, but I think that caution shows that actually for a large number of patients, there is no concern. But the concern is, are there any ones that are not being included, any ones that have self-selected, didn't, perceive some difficulties and then dropped out or what have you. But that's not a bad thing if they've done that, made that choice themselves. I think the caution that we had when we had the cases of full-time total occlusion, like when I started practicing, we're not getting those anymore. And I think that, that's something that's in some people's minds is still a big concern. I don't think it's a big concern, but I don't think I feel confident enough to say, no, we don't have to worry at all.
Okay, that makes sense. That makes sense. Looking at patients, what would be a patient at risk for you, for the audience? What would be a patient that is definitely at risk?
So I think one of the things, it could be worth trialing the binocular treatment and to see how they experience and if they get any symptoms then, and using that information to inform you. And what is their binocular status? Again, I wouldn't be advocating it in sort of your large angle strabismus. And although at which point at what point, what number would you put? Like, what size of angle is too big? I don't know is the answer to that one.
There's a question from the audience asking about an adult patient. Are they more at risk? Who are the adult patients that are being treated, for instance, for these binocular problem or binocular therapies?
I think there's a lot of work that has been done on adults, and so the anisotropes we've not got concerns about. With the strabismic, I think you can make more of an informed choice as an adult. You're making that, right, I'm willing to try this, I'm willing to see what happens, and to have that conversation with the patients. Whereas, being honest, saying there is a risk, it potentially might be minimal, but there is still a risk. Actually, which patients want to make that choice and want to make the decision of whether they put themselves forward to do that or not.
Okay, thank you so much.
May I have a question for?
Yeah, sure, Sudan, go ahead.
Yeah, Anna, and well, I'd like to learn your opinion. I know that you're involved in the British Iris Registry Group, and that was reported as for treatment of resistant intractable diplopia, the opaque IOL implantation in order to reduce the diplopia symptoms. And I remember in a paper they reported as 98 cases with opaque intraocular lenses just to eliminate the diplopia. So do you know among this group there are any patients who develop diplopia after those vision therapies or some occlusions or any other types of treatment in adulthood? Are there any patients in this opaque intraocular lens required group?
Not that I'm not familiar with that group, so I couldn't really comment on that. But in terms of, sorry, excuse me. In terms of yes, there are some patients. I think once they've gone for the opaque intraocular lens, I'm so sorry. Then we don't have any concerns at that point. But yeah, sorry, I can't sort of comment on that. Let me excuse me a minute.
Oh, thank you. So thank you, Anna.
I had a question about anti-suppression of the fovea versus just a regular suppression of anti-suppression of the peripheral fusion. Do you feel like there's any higher risk factors with anti-suppressing the fovea, especially in adults?
Well, that is an interesting question, and I think with a lot of these modalities, so some of them are giving you sort of anti-suppression in various areas of the peripheral retina rather than foveal. So it'd be worth looking at some of the games where the anti-suppression is focused particularly central, and if there is any sort of difference in those, that'd be worth actually having a little look at. Yeah.
So thank you, Anna. And
Thank
so
you.
while the discussion is nice, but we need to move forward. So I'd like to introduce our next speaker, Jonathan Holmes, from USA. So he's going to speak on diplopia, where the problem starts in the retina. Yes, Jonathan.
Great, thank you very much. Let me just share my slides. Okay. Are we on presentation mode? There we go. So yes, I'm going to talk to you now about double vision with retinal problems, and I have no financial interests other than grant funding from the NIH. I'd like to divide these into cases where there's macro misregistration, which is really classic strabismus, where you have horizontal, vertical, and possibly torsion in any combination, and then micro misregistration, which is where you have dragged fovea diplopia, or some of us call it central peripheral rivalry, where the peripheries are fused, but the foveas are not fused. So the macro misregistration or classic strabismus in this environment is often associated with a scleral buckle, but there are cases that don't have scleral buckles, and we'll talk about those. And the ones, and it's been mentioned already by Lionel, with micro misregistration or dragged fovea diplopia, most often have macular pathology, and the most common is epiretinal membrane. And clearly there can be cases that have combinations of these, and one theme that threads its way through the entirety of this symposium is what is the barrier to fusion, and that's really our quest as we evaluate these patients and treat them. So let me start with the first case, which is a patient with double vision following retinal detachment repair, and the patient complains of vertical, horizontal, and twisted double vision. And one approach to this is to recognize that post-retinal detachment, there's often a restrictive component. Often it's the inferior medial rectus or the superior oblique, but it can be any of the muscles. And often there's a sensory component depending on the level of visual acuity. This is a case that I wanted to alert you to this phenomenon, which is superior oblique entrapment. You'll notice here that the patient has problems depressing the right eye and has a hypertropia, and that's in combination with an excyclotropia. So this is something to be aware of, which is when you have a hypertropia with an excyclo, then this is probably superior oblique entrapment, and this is a leash phenomenon of the superior oblique. That should be contrasted with the other common excyclo presentation with after retinal detachment, where you have an elevation deficit. If you have an elevation deficit and excyclo, then you should think inferior rectus restriction. The reason why I'm highlighting superior oblique entrapment is that you have to know about it to know where to look. So here, in superior oblique entrapment, the retinal surgeon has captured the superior oblique unknowingly and dragged it forward to the insertion of the superior rectus. And you very, very often find the superior oblique at the nasal pole of the superior rectus muscle, and that's where you need to look for it. I also want to leave you with some tips on how to approach these post-retinal detachment, post-scleral buccal cases. Often you open the conjunctiva and your heart sinks as you look at this frozen sea of scar tissue. You should expect to need to do some sharp dissection, even to get a hook on the muscle sometimes. Sometimes you can get a hook further back on the muscle, but you often need to sharp dissect forward, and this is something that we don't often do in strabismus surgery, but you need to be dissecting toward the limbus in order to free the muscle from the underlying scar tissue. You also often have to sharp dissect between the muscle and what I call the cocoon, which is the scar tissue around the scleral buckle. And as my mentor used to say after some dissection, now that looks more like a muscle, and you can actually, by careful dissection, often reveal the muscle and allow yourself to be able to work on it. You also need to remember that when you've imbricated the muscle, it's often stuck more posteriorly, and you need to be able to completely free the muscle, and this involves further sharp dissection further posteriorly. Another tip to leave you with is that you do not need to remove scleral buckles, only very, very occasionally. And you can hang these muscles back over silicon bands and leave them intact. So back to this particular case, we recessed the superior rectus for the hyper, we repositioned the superior oblique for the X cyclo, and recessed the lateral for the XT. This patient did quite well, although it reminds us that we don't get complete success in every case. And this patient could fuse with vertical prism, but and in this particular case, it was a combination of the X cyclo, the hyper, and the exotropia that were all the preoperative barriers to fusion. The next case shares some features with the last case in that the patient presented with vertical and torsional diplopia, but this patient did not have a previous scleral buckle, had a retinal detachment which was repaired by vitrectomy. This patient had a small hypertropia, but also had a large amount of X cyclo measuring 10 degrees on double matrix rod testing. On fundus exam, there was clear X cyclo visible by the position of the fovea, but the position of the fovea relative to the disc is not particularly helpful for surgical planning other than identifying the presence of X cyclo. What's more helpful is to put this patient on the synoptophore to determine what is needed to be corrected to improve this patient's symptoms. And in this particular patient, both the X cyclotropia and the hypertropia need to be corrected. So we proceeded with a left Harada Edo resection and a left superior rectus recession to address the X cyclo and to address the hypo. Note that adjustment, the patient only had a small in cyclo, but I see that these patients unwind with time. And so I always aim for around 7 degrees of in cyclo correction. And indeed, this patient did well. So what I want to point out in this patient is that they had X cyclo and hyper associated with a macular off retinal detachment, but did not have a scleral buckle. The last case I want to present to you is a patient with many years of diplopia and intermittent overlapping images. They had already been seen by a retina who had diagnosed an epiretinal membrane, and this patient had good visual acuity. Several speakers have already mentioned this, but you can gain a lot from your history taking. Often these patients have initially single vision when they stare at something, but after a few seconds it becomes diplopic. Looking away often restores double, and typically these are small vertical deviations. You often chase it in clinic with vertical prism. This is central peripheral rivalry or dragged fovea diplopia or micro misregistration. Now, although when we originally recognized this, and Dave Guyton drew attention to it 20 years ago, the fovea may be misaligned in the XY axis, but often these cases have a just scrunched fovea, and that renders a different packing of photoreceptors, and the two foveas are actually in the same place, but the packing of the photoreceptors is different between the two eyes, and that manifests itself with these symptoms. Dave Guyton introduced the lights on, lights off test, and this eliminates peripheral fusion, so allows the patient to fuse centrally. But we described an optotype frame test where you don't have to turn all the lights off, and you ask the patient to look at a single optotype on your screen, and you ask them to look at it for a period of time, a few seconds, and they will often describe it becoming double. You then ask them when it is double, is the frame around the letters double or single? In classic vertical strabismus, everything will be double, as pointed out in an earlier talk, but in this condition, you'll get doubling of the letter, but a single frame. Often when you use prism then to reestablish fusion of the image, if they continue to stare for a few seconds, it then splits again. So this particular patient did have that positive optotype frame test. They did have anisoconia. They did have metamorphopsia. So how do we treat these patients with dragged fovea diplopia? We put together a series of patients and described their outcomes. Dave Guyton has popularized the use of satin tape or a Bangada filter in these patients. And indeed, there are some successes in these patients, but in our series, it was a relatively low success rate. We did early on in our encountering of these patients try ground prism, but ground prism for us was universally unsuccessful. This is also very important to consider when you're contemplating strabismus surgery for these patients, because you need to be able to demonstrate that they can fuse with prism before you proceed with strabismus surgery if you're contemplating that. We did find that Fresnel prism was quite successful in about half of patients. And why was this more successful than ground-in prism? And we believe that this is because there's some blur that's being induced by the Fresnel prism. So you get the advantage of both the correction of the vertical and also the blurring, which is what the satin tape was designed to do and is used by Dave Guyton. We did have one patient in this series who had better symptoms after we treated them with an isoconic lens, but this requires a particular regular anisoconia that's amenable to that, and so these are rare patients. But most surprisingly, we sent some of these patients to our retinal surgeon for evaluation, and he did epiretinal membrane peeling. And we found that we had about a 44% success rate of resolution of diplopia with or without prism after the vitreoretinal surgery. And here's an example of a patient who had distortion of their fovea by the epiretinal membrane. It was then successfully peeled, and you'll see the restoration of normal foveal anatomy in the lower picture. So back to our cases, what were the options? Well, we had the option of treating this patient with a Bangor filter or satin tape or a Fresnel prism, or we could have referred this patient to a vitreoretinal surgeon for consideration of epiretinal membrane peel. Or has been noticed in the question and answers that often you have to explain to a patient that medicine has not caught up with their condition and they need to adapt or ignore their double vision if these other treatments are unsuccessful. But in the history, we noted that our patient actually complained of twisted vision. So this is a very unusual patient, and we put the patient back on the synoptophore, and we found that torsion was in fact a barrier to fusion. So we did an adjustable Harada Ido advancement of the anterior fibers of the superior oblique, and this patient actually did very well with that. So in this particular patient, and it is an unusual patient, a small amount of torsion was the critical barrier to fusion, which again emphasizes the fact that we need to evaluate each patient with that in mind. So my take-home messages for you are: be aware of superior oblique entrapment in the context of a scleral buckle and know where to look for that superior oblique tendon. After a vitrectomy for a macular off RD, you can have symptomatic excyclotropia, which can be addressed with torsional surgery. And be aware of dragged fovea diplopia. Consider sending these patients to your vitreoretinal surgeon for consideration of VR surgeon, but also evaluate them for other barriers to fusion. And in closing, I would like to invite you to our ISA meeting in November in Buenos Aires. And please feel free to look at that website. And I'd like to invite as many of you as possible to join us then. Thank you very much.
Thanks, Jonathan. This was a really excellent presentation. So, may I ask a practical point regarding this dragged fovea issue, the opto-time frame test? You know, in the standard visual charts, there's the coincidence test with a rectangle, with a square and a circle in the middle. Do you think we can use this for this purpose? Because it looks to me quite useful in clinical practice, because the middle is a circular thing that also eliminates the torsion, and the surrounding part is a square, so then you can also see the torsional element, and it also seems to be quite similar with the optotype frame test without using any polarized glasses and so on.
No, that's a very interesting idea. I would have to look at the angle that the square is subtending, because it needs to be in the periphery, because the critical phenomenon that's happening here is the difference between peripheral fusion and central fusion. And so the nice thing about a screen around a single letter is that the screen is far enough into the periphery that you're evaluating peripheral fusion at the same time as central fusion. So, but I think that deserves exploring.
Thank you. And also, would you consider some, well, you've demonstrated very complex case, including vertical, horizontal, torsional, and so on. But in some more simple ones with the retinal issues, sometimes toxin could be helpful, especially if it is performed in the early stage. And I just wanted to learn your opinion, and what do you think on that?
Yeah, I think there are a variety of approaches, particularly in the complex cases where it's not clear whether they can fuse, because historically, botulinum toxin, and I know you've spoken about this, can be very useful in establishing whether or not the patient can fuse. I think for those of us who use less botulinum toxin, I think we rely on the response of the patient over prolonged testing in the office using the prism, and then if there's a torsional component on the synoptophore. I think that sometimes, and I've sort of learned this over the years, that I've not put the prism up for long enough. So I'll often put prism in a pair of trial frames and have the patient sit for a while to establish whether or not fusion can be restored, or even sit for a long while in the synoptophore. Occasionally, I found that a very brief exam in the synoptophore doesn't give you the information that you need. So the idea of prolonged testing or prolonged trials, I think, is the theme. And Botox gives you a very long trial because there's a period of time where the eyes are much better aligned, and then you can assess over a longer period of time whether fusion whether comfortable fusion is possible.
Can I ask
Thank
a
you.
short question? Jonathan, I love how you are an ambassador for the synoptophore, but I just came back from the iPad project in the Gambia. They don't have a synoptophore. Do you have any other ways for your torsion measurements or experiments?
Yeah, no, I feel sorry for people who don't have access to a synoptophore orthoptist to know how to use it, because what I found over the years is that there is no cutoff for a minimum amount of torsion that's a barrier to fusion. It appears to be a very individual thing. So we all have patients who, let's say, have 7 degrees of ex-cyclo on double Maddox rod testing, and some of those patients fuse very nicely and they don't need any torsional correction. And there are some patients who are desperately and terribly symptomatic with that same amount of torsion. So I think that we're all looking for ways where we can correct torsion, and then assess what the patient's response is to that. There is a prism called a Dove prism, which actually allows in free space you to tort the image, but it relies on total internal reflection. And therefore, the image is flipped right-left. So I know a few people have considered using targets that have left-right symmetry, and then by correcting that, but you almost need an optical bench because you actually have to align that Dove prism perfectly. And then I would also argue that the visual environment that you're asking the patient to look at through that Dove prism isn't a real world environment. It's a single optotype with right-left symmetry.
Thank you.
So you need a synoptophore or an orthoptist who knows how to run it.
Thank you. So could you, Jan, invite the next speaker?
Yeah, the next speaker is Professor Fiona Rowe, and she, as I already said, is a leading academic voice in orthoptics. Really pleased to have her here. Fiona, over to you.
That's great. Thank you, JR. Can I check you can see my slides?
I can.
That's great. Thank you. So hello, everybody. It's a real pleasure to be involved in this webinar. So to start with, my slides moving forward. It's important, first of all, that the underlying cause is treated, as many cases will resolve when the primary condition is controlled. But our non-surgical management options will range from using head postures, prisms and occlusion, and through to pharmacological agents. So starting with compensatory head postures, your patient may well have adopted this themselves already, but if you've got somebody with an immediate presentation, you may see the patient before they've adopted a head posture. And at that stage, you can advise the patient on how best to position their eyes and to immediately compensate. And for most patients, you'll find that the eyes just need to be positioned away from where they've got their double vision. But occasionally, it may be better to displace the diplopia images wider. So for example, if your patient has no fusion potential, so here the head posture is used to widen the gap for easier viewing of the clearer image. But prisms really are usually our first line option when deviations are small to moderate in angle and also relatively concomitant. However, we need to note that prisms will perform poorly in incomitant deviations where the angle varies significantly with gaze. So in general for prisms, the question to ask first of all is why not? And my usual practice will be to try prisms with as many patients as possible because it's better to maintain binocular single vision. And in addition, keeping both eyes open maintains good peripheral visual fields, and that's important for mobility in patients who may have other disabilities because of a neurological condition. Our measurements are absolutely key to deciding what strength of prism is needed. I'll measure near versus distance because the prism strength that I need may differ for both of these distances. And it's really important to check the patient's subjective needs versus the objective angle. The amount of prism needed to correct diplopia often depends on fusion reserves. And we know that long-standing deviations will have an extended fusion range in certain conditions. So we will then need to correct less of the angle. We can tilt a prism if there's a combined horizontal and vertical effect. However, presence of torsion is usually a contraindication to being successful with prisms. And we do need to warn patients about the potential for blur and for color fringes, particularly with higher strength prisms, so that the patient's expectations are more realistic. So Fresnel prisms really are ideal for when we first correct diplopia. They're readily available, they're relatively inexpensive, and we typically use them in the short to medium term and when things are changing with the condition. Now we can use a prism, we can cut the prism to cover the entire lens, or it can be a sector cut to correct diplopia at either near versus distance or in a specific gaze position or direction. And in the longer term then, when deviations are stable, we can incorporate prisms into glasses prescriptions. And here, usually the prism strength is split, and that's between the two lenses to improve optical quality. Unless there's a specific reason to incorporate prisms for large angles, it usually isn't appropriate because of the size of the prism and the weight of lenses, plus the prismatic effects that you might have. So occlusion is simple but very effective for both monocular and binocular diplopia. It provides immediate relief while the underlying condition is stabilizing, or until further management with prisms can be arranged. It's particularly helpful acutely where patients cannot access the eye clinic, and our neuro rehab units and neurological wards have a stash of eye patches on the ward to give to patients who have diplopia. Occlusion will be probably the most obvious choice for eliminating diplopia if prisms are not suitable. So that would be in examples like large or incomitant deviations. But it may also be where the patient has poor prism tolerance because the prism strength is too high, or if there's poor or no fusion. Now, like prisms, there are several occlusion options. We can have opaque occlusion to completely eliminate diplopia, but that may be cosmetically undesirable. So in those situations, tape over glasses may be preferable to a black eye patch. We can also look at using Bangerter filters or frosted tape, which partially blur the image, but often they're quite well tolerated. And there will be some cases of intractable diplopia where an occlusive contact lens or an occlusive intraocular lens may be used. And again, don't forget the option of sector occlusion, which can be really helpful for diplopia that only occurs in certain gaze or distance positions. Next, we can consider lenses, and indications for using lenses will be small deviations, comitant stable deviations, and also those who have accommodative elements. Now, we can use lenses to generate accommodative effects, and if we give or increase a plus lens, this can improve control of an esodiviation so that diplopia can be controlled. And the same for increasing a myopic correction to improve the control of an exodeviation. So a couple of examples would be the use of a NIRAD for convergence excess esotropia, but also minus lenses for intermittent distance exotropia, where these cases have underlying high ACA ratios. And then also vice versa for decreasing lens strength. And examples here would be for treating small decompensating ESO or exophorias. If you have a patient who's got a high strength of lens prescription, it is possible to consider a decentration effect. We know that there can be an induced base-in prism through the extremity of a concave lens, or an induced base-out effect with a convex lens, and it's possible to deliberately decenter a large prescription to give a prismatic effect in primary gaze. But here we have to have a very careful consideration and an offset against the effect that might have on visual acuity. It's important to optimize refraction for monocular diplopia, and also we can consider rigid contact lenses to use for irregular corneas that are causing monocular diplopia. But for binocular diplopia, it is sometimes possible to use a high prescription lens monocularly to fog vision for relief of diplopia. We can't forget exercises. Exercises work well with vergence systems, and they're particularly useful for convergence insufficiency and decompensating phorias. Now, most often we're working with exos for this, and we can start with convergence push-up exercises. For lots of patients, that on its own is enough, but we can progress to using stereograms to fine-tune that result. And also we can use fusion exercises, which are easily done using prism bars. I don't like to send home my prism bars. They may not come back to me. So we tend to use homemade prism bars, which are actually very, very easy to make. And then lastly, looking at pharmacological options. For monocular diplopia caused by ocular surface disease, then drops or ointment to treat the condition may lessen the diplopia. Binocularly, we know phospholine iodide is no longer easily accessible, and what we need to then consider is occasionally using drops to induce pupil miosis, which can increase depth of focus, and that means less accommodative effort is needed. Now, very occasionally, this can be useful in the very immediate post-operative treatment of small angle convergence excess ESOs, because we want less accommodative effort to maintain binocular single vision. Another cause of diplopia could be convergence spasm, and often our first line of treatment for those is atropine to break the accommodative effect and reduce the convergence spasm. And then there's the option of botulinum toxin, and there are many conditions in which this is indicated. These range from the use in acute onset deviations, particularly neurological cranial nerve palsies, so alleviating the diplopia and or reducing antagonist muscle contracture. But it can be used in the management of infantile esotropia, postoperatively with residual or overcorrected deviations, but also with late recurrence of deviations and late onset concomitant strabismus. There's a long list of other indications, and these range from patients who will choose to have maintenance BT over the long term. There will be some patients where surgery is just not possible. There may be occasions where there's a long-standing convergence spasm that is atropine intolerant, and we can't forget its role in giving useful diagnostic information for the risk of postoperative diplopia. So to summarize, non-surgical approaches are typically our first line steps in managing diplopia. They provide rapid symptom relief, and they're particularly useful while the condition is evolving. And they may help patients who are not surgical candidates or those who prefer conservative management. So thank you for listening.
Uh, Thanks, Fiona, for this excellent talk. Unfortunately, because of the time conflict, we need to move forward and then if we have, we can make a short discussion at the end of the last two presentations. So I'd like to invite Burton Kushner. And yes, Bert. Then so he's going to speak on post-strabismus surgery, diplopia, pearls for prevention and treatment.
Thank you very much. I am on the advisory board of Novasight, and that relationship has no bearing on this talk. I first want to just briefly mention what I call predictable postoperative diplopia, and that occurs in a patient who is diplopic preoperatively, and you have an unsuccessful surgical outcome. You have a lateral rectus paresis, you don't get the patient straight, they'll be diplopic. Or there can be patients who are not diplopic preoperatively, yet you can predict circumstances where they will be after surgery. If you overcorrect an adult exotropia, for example, or overcorrect a superior oblique palsy. And in these cases, the decision-making is fairly simple. You just have to improve alignment, either with prism or reoperate to align the patient better. But what I really want to focus on is the non-predictable postoperative diplopia. That's a patient who preoperatively is typically constantly strabismic and suppresses, is not diplopic. And we'll talk about the preoperative evaluation and decision-making. Every adult patient that I have with constant non-diplopic, possibly variable, but constant strabismus without diplopia undergoes these tests. I, in the office, hold a prism to offset the deviation, to slightly overcorrect the deviation, and slightly undercorrect the deviation. And in my experience, if they are not diplopic with this prism testing, they never get permanent post-op or even long-standing postoperative diplopia. And I'm going to be talking about the results of this series I published of 424 consecutive patients, adults with constant strabismus that I operated on, looking at the incidence of postoperative diplopia. Now, in those patients that are diplopic with prism, I ask further questions. Are the images far apart? Are they crossed or uncrossed? Both tell what's going on sensorially. Does the patient have ARC? Are the images almost touching, but they can't fuse, in which case you're probably dealing with a disruption of fusion. And finally, there are the patients that have what Art Jampolsky labeled lost or confused localization. This is similar to what Kyle Arnaldi described in patients with central nervous system disease, but these patients are different because their diplopia only would come on immediately after surgery. And this is a very important finding. These patients see double, but they can't relate where one image is in space compared to the other. Hard for me to understand, but that's what they say. Now, interestingly, if the patient is diplopic with prism, I found that of the 424 patients I tested, 34%, 143, were diplopic when I offset them with prism in the office. Only 40 of the 424, 9% of the total, or 28% of those who were diplopic with prism, excuse me, that advanced too quickly. Oops. Only 40 of them were even temporarily diplopic with surgery. And in all of them, the diplopia resolved by 6 weeks after surgery. So that's, to me, very interesting. Only 3 of the whole cohort, 424 patients, less than 1% of the total, had what I would call intractable diplopia, diplopia lasting more than 6 weeks, is how I define that. So this means that if a patient is not diplopic with prism testing, they will not be diplopic for certain if they have surgery. If they are diplopic with prism testing, the best you can tell is that there's a tiny chance of being diplopic if aligned. Now, some of these patients were concerned, And if a patient's, they don't want to risk having double vision. If they're concerned, I give them a trial of a Fresnel prism for 2 weeks to offset the deviation. And I did this in 18 patients. In 8 of those patients, the diplopia resolved by 2 weeks of prism wear, and none of them were diplopic after surgery. In 10 of the patients, the diplopia persisted after 2 weeks of Fresnel prism, and they elected to have surgery anyway, and none of them had persistent diplopia after surgery. 7 of them actually were diplopic as they went into the operating room and weren't diplopic immediately after surgery. And I find that very fascinating. 3 of the whole cohort of 424 had persistent diplopia. Every one of them had lost localization on preoperative testing. And actually, all 3 had their diplopia resolved, but really after several years. So what do you tell patients? If they're not diplopic with prisms, say there's a negligible chance of persistent postoperative diplopia. If they are diplopic with prisms, there's a tiny chance of postoperative diplopia. And if they're still concerned, a 2-week trial with a Fresnel prism may put them in the no-risk category. So in summary, preoperative prism testing, a negative test, 100% predictive value of no postoperative diplopia. A positive test, only a 2% predictive value of persistent postoperative diplopia. Lost localization is the worst prognostic sign, and all 3 patients with persistent diplopia ultimately resolved. I have never had to operate on a patient to return them to their preoperative deviation to get rid of diplopia. You can always keep the good alignment cosmetically and offer an occluding contact lens. And with that, I thank you.
Thank you so much for this excellent talk. And we are going to make a brief discussion for the last 2 papers. And well, may I ask, well, I'd like to say that a few years ago, we published a small series about the cases with acquired loss of vision with intractable diplopia. In our series included the central nervous system problems and also long-standing uncorrected aphakia. And among the 22 patients when toxin was injected, we found that 64 of them regained fusion despite they were having intractable diplopia before. And in many of those, prisms were tried first. And we concluded that this different response to prisms and botulinum toxin could be because of the deteriorating effect of even the conventional prisms. Because in a nice study of Verena Trutman many years ago, she demonstrated that not only the Fresnels but also the conventional prisms had an adverse effect on visual acuity on a lower level. And in these patients who are on limits, possibly this may have a negative effect to regain of fusion. And that is why we concluded that botulinum toxin, despite prisms failed, toxin was successful in real life conditions. And I would like to learn Fiona's opinion, and then I would like to address this question for the postoperative diplopia thing. And as a frequent botulinum toxin user, in those who tell that they see double with the postoperative diplopia test with prisms, my preference is always to inject botulinum toxin to be on the safe side. Because despite it's rare, I think we need to identify the patients who will remain diplopic, because when it is the case, it's a nightmare, and they are they may become the nightmare of the doctor as well. It's a lifetime thing because. So may I first learn the opinion of Fiona and then give the word to Dr. Kushner? Is that okay?
Yeah, so I mean,
Yes, Fiona.
standardly when we've got a patient complaining of diplopia, or sorry, not complaining of diplopia, you want to find out if by altering the angle surgically that might risk it, then we will do prism testing in the clinic. And you may get somebody who has absolutely no response at all, you think they're safe, and you'll get others who are complaining of diplopia. But again, our route in those would always be to refer to have botulinum toxin done before the surgery. I work in Liverpool, and I know Ian Marsh has done a huge amount of work on this as well and published widely, that he's found very similar to what you've said, Seyhan, that patients who were complaining of diplopia, once they've had Botox and they've had that longer period of time with better alignment, then actually they're fine. They're not complaining of diplopia, and then they're safe to go on and have surgery.
Thank you. Yes, Bert, please.
Yeah. So I think what you said makes perfect sense. Prisms do degrade vision, and that Fresnel in particular, but even grounded prism, and that can play a role. I remember so well this patient that had a lateral rectus paresis that I was temporarily treating with Fresnel prism, and she came in wearing the prism, and she said, "This is great, I don't see double." And it turned out the prism had come off. She put it back on and didn't know that it had to be base in, base out. And it was going exactly in the wrong direction. And she had, instead of a 30 prism diopter deviation, it was 60. She didn't see double because the 30 prism diopter Fresnel blurred her significantly. So I think that plays a role. The patients that I'm talking about that have the intractable diplopia after surgery are ones that end up with good alignment. Obviously, if the patient's not aligned, it's not so complex to understand. So if the eyes are almost perfectly straight, I'm not going to be, or perfectly straight, I'm not going to be treating them with prism. It's interesting. I remember very early in practice, when I was probably insecure about every patient I operated on, I had a dream. I've never said this in public. I had a dream the night before I went to that I was doing surgery, that I operated on a patient with an exotropia who was NLP in both eyes. He was totally blind in the dream and wanted cosmetic surgery. And I dreamt that I operated on him, overcorrected him, and he now saw double. And I felt terrible. And he said, "Well, before surgery, I didn't see at all, and now I see double. That's twice as good as seeing single." And in fact, as we know, my patients tell me double vision's not even half as good as seeing single. So it's an interesting subject.
So thank you so much. We have some more questions in the Q&A box, but I would like to ask the speakers to answer them afterwards. So this webinar is recorded, and it's going to be, you will find it in the IPOSC website, and it will be there forever. So, and then you will find all the answers. And so I'd like to ask the speakers to answer these questions afterwards. I'm so sorry that we need to end this webinar with announcing the next webinar of IPOSC, which is going to be on a very interesting topic, New Horizons in Myopia webinar. It's going to be on treatment and surgical breakthroughs on myopia, and the date will be 3rd October 2026. And I would like to thank all the moderators, the IOA, ACO, for this great collaboration. And I would like to thank all the speakers for their excellent talks. And also I'd like to thank all attendees for being with us in this weekend day, and hope to meet you again in our next webinar. Thank you very much. Tamara, do you have any closing remarks?
No, just thank you for everybody, and thank you to all the speakers, moderators, and Dan. And let's have a group photo for us at the end.
Thank you. Of course, Dan is the secret hero of this webinar. Thank you.